In the following video, Dr. Hao Zhang is going to show us a very challenging and complex case of recurrent melting and perforations that in the end ended up with a rare complication of intracorneal extrusion of the intraocular lens. Also, he's going to show us the surgical video of how they managed this serious complication, and also he's going to do a review of the literature about what is the definition of this rare complication and how has been managed according to the scientific literature. Thank you, Dr. Hao.
The transcranial extrusion of intraocular lens and the challenges of triple penetrating keratoplasty in autoimmune corneal disease. In this video, we have no financial disclosures. Today, I will share this topic from following 4 points. First, to present a case of intracranial extrusion of intraocular lens. Second, to introduce intracranial extrusion of IOL and its causes. Third, to explain the pathophysiology and the potential benefits of intracranial extrusion of IOL. Finally, to describe the management of intracranial extrusion of IOL. First, case report. The patient is 64 years old female. She has a history of Sjogren syndrome and rheumatoid arthritis. Her main complaints are recurrent corneal ulcer in right eye, decreased vision, dryness, redness in both eyes. She had cataract surgery in left eye 7 years ago. In 2020, the patient's vision was reduced to counting fingers and 10 centimeters with normal intraocular pressure. Here we can see the patient's right eye presented with significant symptoms, including a corneal ulcer, neurovascularization, lymphoma, and cataract. At this stage, we initiated further immunotherapy adjustments along with radiofrequency ablation. We also applied Avastin to eliminate the neurovascularization, preparing the patient for the upcoming penetrating keratoplasty and cataract surgery. Finally, we performed penetrating keratoplasty on patient's right eye in July 2021. Initially, the surgery seemed to go well, and the OCT scan from July showed the newly transplanted cornea in place. However, 3 months later, by October 2021, we observed serious complication. Here we can see the development of descendant cell, where the corneal tissue thins drastically and the descendant membrane began to bulge outward. After 1 month of further immunotherapy and PRP treatment, the patient showed some improvement. However, due to the ongoing issues of corneal integrity, we decided to proceed with second PKP in November 2021. Here you can see the clinical image from October 2021, showing the development of descendant cell. After 1 month of treatment, we performed second PKP to restore cornea. The post-operative OCT image from November 2021 shows the improvement in corneal structure after second PKP. Several months after second PKP, unfortunately, the patient developed a spontaneous corneal ulcer despite adjustment to her immunotherapy and regular follow-up. By August 2021, the ulcer progressed to a corneal perforation. To manage this, we performed an amniotic membrane transplant covering the perforated area to promote healing and prevent the further damage. The patient then returned to her hometown, but upon her next visit for follow-up, the corneal condition has worsened significantly. Here we can see this complication, an intracorneal extrusion or IOL. As you can see, both slit lamp imaging and OCT scan show that the excluded IOL has become integrated into corneal tissue. The haptic or IOL is also exposed. The patient's visual acuity in right eye became very bad with only light perception. Additionally, intraocular pressure in right eye was elevated 32. Given this situation, we decided to perform a large diameter PKP to resolve this issue.
In this video, we observe the patient's cornea. Notice the edematous cornea and the extruded intraocular lens, with the haptics visible at the 10 o'clock position. Around the 9 o'clock position, remnants of an amniotic membrane can be seen sutured to the cornea. We measure for a 10 mm diameter trephine, which will be used for the penetrating keratoplasty. The donor cornea is also measured appropriately to match the excision site. Next, we excise the decompensated cornea, and all adhesions are carefully dissected to ensure a well-formed anterior chamber. Special attention is given to freeing the uveal tissue to restore the anatomy of the eye. After all the adhesions are released, we proceed with the transplant. The donor cornea is placed on the recipient bed and suturing is performed to secure the graft in position. Despite the successful completion of the corneal transplant, the right eye still presents with aniridia and some remaining blood remnants in the anterior segment. While the procedure was technically successful, the prognosis for visual recovery remains uncertain. The patient will require close follow-up and further management to assess the final visual outcome.
Now, combining our case with published reports, we will first review IO extrusion, definition, and courses. Transcranial extrusion, or IOL, were first reported in 1983 in Ophthalmology. The report described it as protrusion of intraocular lens through corneal tissue. It's often a complication, especially in patients with corneal issues that weaken corneal integrity. On the right side, we can clearly see this case is very similar to our case, which is shown on the left. Both cases exhibit distinct signs of IO extrusion through corneal, with significant corneal degradation with visible IO haptic extrusion. The primary causes and risk factors for this complication mainly include corneal decomposition, corneal ulcer, perforation, and ocular pressure inflammation. In our case, we believe that all three of these factors were present. Our patient had severe autoimmune disease, had undergone multiple corneal transplants due to corneal ulcers and melting chronic ocular inflammation, and due to abnormal anterior segment structures, experienced significantly elevated intraocular pressure. This finally led to occurrence of this complication. On the left, we can see a more typical anterior segment OCT image from other reports, where the intraocular lens is perfectly fused with corneal. On the right, we can see our case. Now let's discuss the pathophysiology of intracorneal extrusion, or IOL, and its potential benefits. In this slide, we explain how intraocular lens moves and attaches to cornea. On the left, we see how corneal damage and fluctuating intraocular pressure cause the IO to shift. Corneal inflammation breaks down tissue, leading to ulcer and perforations, while sudden intraocular pressure changes destabilize the eye, allowing the IO to move. On the right, inflammations cause the fibrin deposits, making the IO stick to cornea, and the cornea weakens the IO's haptic fuses, creating a stable but abnormal connection. Here we explore some unexpected benefits of IO extrusion. While it's generally a serious complication, a few positive outcomes have been observed. First, preservation of eye structure. Even as IO extrudes, it may help maintain the eyescape and prevent further damage. Second, preventing infection. The IO can act as a barrier, protecting against infection and limiting further harm to eye. On the right, the histological image shows the anterior surface of IO is covered by conjunctive epithelium with signs of metaplasia, along with chronic inflammation. This likely contributed to adhesion between corneal and IO. Finally, let's discuss the management of this complication. First, regular follow-up is essential to monitor symptomatic diseases, intraocular pressure, and any signs of corneal deterioration. Early invitation focuses on addressing issues like progressive corneal thinning, infection before they worsen. In our special case, due to the lack of regular follow-up, the IO became fully fused with corneal, making simple adjustment or removal impossible. With the corneal covered by amniotic membrane, a large diameter penetrating keratoplasty became the most viable option. In conclusion, the transient minor wound dehiscence, prolonged lack of ophthalmic evaluation, intraocular lens migration, absence of corneal healing, and prolonged preservation of stereo intact globe are the key factors that allow this complication to persist. Hydrophobic IO may serve as a provisional temporary corneal substitute in treatment of complex corneal disease. Thank you for your attention.